The more important thing is to talk about acute asthma management. So when patient come in respiratory distress, then you diagnose it as acute exacerbation of bronchial asthma, or could be multi-trigger wheeze. So the treatment is kind of the same. So the first thing first, you want to classify how bad is the exacerbation. I think mild, moderate is quite straightforward, but I think it's more important to identify the severe and life-threatening bronchial asthma. So when we talk about severe asthma, the saturation will be less than 90 or 92. It depends on the protocol which one you refer to. And then severe life-threatening will be hypoxic plus apparent cyanosis. Okay. And then the lung auscultation finding, for severe asthma, you can hear the audible wheeze. So without using the stethoscope, you can hear the wheezing. And then for life-threatening will be silent chest. Okay. Then for severe asthma, the heart rate will be very tachycardic. For infant, more than 160. For bigger children, more than 120. For life-threatening, there will be bradycardia already. Okay. But one thing that always easy to gauge is the appearance. For severe asthma, children will be agitated. For life-threatening, they will be drowsy already lah. Okay. One more thing is the respiratory stress signs, which is your use of the accessory muscle. When you start using your suprasternal, your sternocleidomastoid, this fall under the severe life-threatening asthma already. Okay. In infant will be the head bobbing. Okay. So once you classify the severity, then you probably know you want more advanced treatment other than the nebulization of salbutamol or atrovan plus hydrocot. So you probably need to use the more drugs to break the bronchospasm. Standard management, you probably will start patient on face mask, nasoprong, or any other oxygen support. Then you probably give patient nebulized salbutamol. So, but don't give the MDI lah in the severe asthma, because patient already hypoxic. If you use MDI, you will cause more hypoxia, because the MDI is under 21% oxygen, and you will put the mask covering the nose and the mouth, causing more hypoxia. So that's why we prefer to use the NEP salbutamol driven by oxygen. For houseman and medical student, please know your NEP salbutamol dose properly. For less than 2 years old, use 2.5 mg, which is half an ampule of the 1 ml. So you give 0.5 ml mixed with 3.5 ml to make it 4 ml before you give the NEP. More than 2 years old, you give 5 mg or 1 ml, and you mix with 3 ml normal saline to make it 4 ml. But please check the concentration of the NEP ampule. Some of it may be 2.5 mg per ml, some of it may be 5 mg per ml. So yeah. Another medication that you should know the dosage is your ipratropium bromide, which is your atrovan. For less than 5 years old is 250 mic per NEP. For more than 5 is 500 mic per NEP. Okay, this is another common drug. You should know the dosage. Okay. I think you all should familiar with the dose of hydrocot, which is 4 mg per kilo. Max dose is 100 mg. Preferably, those who cannot tolerate orally, you give the IV hydrocot. But those able to tolerate, you can give the prednisolone. The efficacy is the same. It does not differ at all in terms of efficacy. It just matters if patient cannot take orally or patient vomiting. Okay. One more thing is about the dosage for prednisolone is 1 mg per kilo. please know about the maximum dose, up to 40 mg, but most of the time we give 30 mgs, which is about 6 tablets. One tablet is 5 mg. Okay. Another reason why IV hydrochloride is preferred in severe asthma or life-threatening asthma because of patient is agitated is one thing. If patient is drowsy, definitely they cannot take orally. You must give IV hydrochloride. If you give them orally in a drowsy patient, you might cause aspiration. Yeah. On top of it, you want to give your back-to-back nebulization, either back-to-back Atrovan 3 times every 20 minutes or continuously, then reassess. Okay. So the other option, you can use your subcutaneous tributaline. So the dose, or you can refer to the books. I'm not going to give you the dose. So this is the drug that should be available in the emergency trolley. So you can just break the ampules, shrink it out, and then give it to the patient subcutaneously. While doing that, you may want to order your IV magnesium sulfate or IVI salbutamol. Those will take time for the nurse to prepare. So while you do that, so you may give your subcutaneous tributaline. Okay. The next drug is your IVI magnesium sulfate. Magnesium sulfate is kind of magic drug given in a lot of conditions. One of it is bronchial asthma. It somehow help with the bronchodilation to break the bronchospasm. How it does is not really known, but it somehow help a lot of patient lah. So most of the patient will kind of respond to magnesium sulfate lah with their asthma. It's not really severe. But just be wary of the side effect, which is the hypotension. So it may cause hypotension, so you make sure the blood pressure is alright. If patient come with history of poor oral intake for the past few days, they may be dehydrated. The volume in the body may not be good. So if you give myself in the inadequate volume patient, so they may exacerbate the hypovolemia and may cause hypotension. So you might want to give bolus or prepare to give bolus while you giving the infusion of magnesium sulfate. Okay, so the next drug you may consider is your IVI salbutamol. The problem with IVI salbutamol is it may cause tachycardia. So the heart rate will be 20-30% higher than the baselines. It may induce arrhythmia in certain patients lah. The most common one that we see regularly is your SVT, which is your supraventricular tachycardia. So be very worried lah when you use your IVI salbutamol. So it's one of the option to break the bronchospasm. Okay. Alright, so the other drug you may consider is the IV aminophylline, but I rarely use it because of the low therapeutic range and also side effect as well. This one only preferred to be used in the ICU setting. Okay, so while patient already on this medication, if the spasm still there, then patient still drowsy, is not improving, so you might want to step up your oxygen support, which is your non-invasive ventilation. You may consider your CPAP or BiPAP with higher PEP, at least about 7 or 8, to help with to relieve the bronchospasm. Okay, so even if that not helping very much, so you might want to consider intubate. So about intubation in bronchial asthma, so there are certain drugs you may prefer to use as your induction. You may use your midazolam, okay, but ketamine is a preferred drugs to use on top of your midazolam because ketamine have effect of bronchodilation, so it helps with the bronchospasm. So avoid morphine. Some morphine may cause bronchospasm, so we prefer to use ketamine over morphine. So on top of it, you may use your muscle relaxant as well to help with that thing. So if you use ketamine may induce a bit more secretion, so you might want to add on atropine as well to reduce the secretion. Okay, so when you already intubate, so then the next thing how you want to ventilate lah, which is your ventilation strategy. So ventilation strategy in bronchial asthma is to use higher PEP. So because higher PEP to kind of help the bronchospasm. So so sometimes we use 7 or 8 on top of the PIP, and then the continuous snap every 4 hours, and then on top of it there is IV isobutanol, then IV Maxop as well. Okay, all right. So but that's not the issue here lah. The issue here why patient need to be intubated, because this indicate poor in treating a patient properly, whether at the detection processes or whether during the follow-up, not ensuring patient compliance if patient on the medication. If patient already on follow-up still coming with severe asthma, that show how poor is the care during the follow-up. Because when we treat patient as asthma, when you give them follow-up, you start them patient on prophylaxis. The main aim is to reduce the exacerbation. If there is exacerbation, the aim of the treatment also want to reduce the severity of the exacerbation, so that they don't come with a very very severe attack or life-threatening attack. Alright, so that's why very important to educate patient, ensure compliance, the technique of using air chamber, and find out any other triggers that may contribute to the why the asthma is very difficult to control. Okay, I think that's roughly the basic of the management in acute asthma. So I think the next thing we're gonna talk about management of asthma in general lah. Okay, so I think wait for the next videos. Okay, this is gonna take a lot of time to talk about. It's really a lot.